Right, good morning, everyone, and welcome to session 2 of our RaCEEs course. Today, we're going to talk about key attributes of an economic evaluation. And I'm running today's session with Luís. Luís, would you like to introduce yourself?
So, hello. So my name is Luís. I'm a lecturer at Lancaster University, and I'm running this. I'm the lead for the Theme 7 in these RaCEEs.
Thank you very much, Luís. As usual, I have to say this: the session is being recorded, and it will be made available on the ARC West Coast YouTube channel after this morning. If you have any questions about the recording, do let us know. I think we got maybe a few people who didn't attend the first session. I think Pooja for sure. Pooja, would you like to introduce yourself very quickly? Just to indicate where you work and your motivation behind joining this course.
Yeah, I'm a professor in suicide and self-harm prevention at Liverpool John Moores University. And basically I do a lot of work with third sector and hospital data as well. But with the third sector, there's always a lot of issues of the data not being great and not being able to do economic evaluation. So I'm basically trying to upskill myself to be able to contribute more to that element of some of the projects I'm working with. And I'm hoping after this to do another maybe master's course or something on health economics.
Oh, brilliant. Thank you. I'm just going through the list of people. I think Mariam, you weren't there the first session, if I remember well. Would you like to introduce yourself as well? Maybe Mariam can't hear us or can't unmute herself. Okay, I'll just carry on then. Okay, let's make a start. Okay, I would like to thank everyone for doing the homework in the last couple of weeks. The homework, as you know, was about selecting an economic evaluation for each team. This is where we are at the moment in terms of the choice of the economic evaluation for each team. So for team number 5, music therapy, we got this economic evaluation, which is economic evaluation of patient-directed music intervention for ICU patients receiving mechanical ventilatory support. Kath, would you like to say something about the choice or any information?
Sure, we all had a good look, but there wasn't very many economic evaluations done in this area. So this is the only one that we could find that's a full economic evaluation. So this is the one we've gone for, but it is music therapy intervention for ICU patients. And so it looks like it's going to be a good choice. And I think
thank you,
everyone's agreed, so.
That's great. Oh, that's good. Housing. So team number 6, Andy, is still pending, but I think you're getting there with the decision, isn't it?
Yeah. Lucy's very kindly identified a paper that she thinks we should have a look at. I'm just waiting for everyone else to have the opportunity to decide as well which one they think would be best. So if everyone could have a look and make a decision by the end of today, that would be really helpful. Thank you.
Thank you, Andy. Team number 7, maternal and neonatal care, Luís.
So we had 4 choices, very good choices, but I decided to exclude 2 because one of them was very good, but it was very overwhelming, the results, and I just thought maybe we couldn't do much with it. The other one was fantastic, but it was still a protocol, so when it's out, it could be an interesting one to have in here. And then we had 2 very good ones. And I think I'm kind of being slightly as a dictator in a bit, because they are both very good, and I think we could do amazing work with the 2 of them, but one of them is more direct into talking about qualities and talking about ICERs and so on. So I would think it would do a better fit with this course. So I'm kind of pushing my team into that direction, and they seem to agree. I think we are going with cost effectiveness of real-time continuous glucose monitoring to target glucose control in preterm infants.
Perfect. Thank you very much, Luís. Team number 8, acute healthcare. the economic evaluation is cost effectiveness of monitoring patient post-stroke with mobile ECG during the hospital stay. Misael, would you like to say something more about it?
Yes. Can you hear me? Okay.
A bit, if you can turn up the volume a bit more, I think.
Okay. We choose this one because there were two options. Both are right. I think they're great. But this one just is more up to date, so it's more recent. And then maybe we can choose the other, but we need to search more if there is another, maybe economic evaluation more recent on that same topic. Or maybe the technology is readily accepted, or maybe not. So maybe things could change in 10 years. So that's the only reason we chose this one. So I think we will be a good choice for this.
Thank you, Misael. Great. And for my team, for Young People Care, I decided in the end to go for this one, cost effectiveness of mental health drop-in center for young people with long-term physical conditions. There was another option as well, which is a paper on an education intervention for young people with diabetes. Similar to Misael, the only reason was on the date of publication. Like this one was more recent, so there were all exceptional choices and very good economic evaluations. But I just decided to go with a more recent paper. Okay, just want to say that the PDFs are on your TeamSpace, or they will be on your TeamSpace very soon. So you will be able to access the PDF and work on the papers maybe from the next few days. Right, this is session 2, and we are going to explore a bit more now the methods of an economic evaluation, and we will try to describe the key attributes of an economic evaluation together. But before we do that, I wanted to talk a bit about the different sections of our commentary. So at the end of the course, we will have a manuscript. We will write up a manuscript together, and it will have different sections, which I'm sure they're going to be familiar with many of you. So we will have an introduction, method, results, and commentary section. In terms of the introduction, we will write that as a last thing to do. So we will try to write that up after session 6, but we can tell you now that we are going to try to include information about why the economic evaluation is important and how it has additional knowledge. In terms of the method and the results, is simply a matter of kind of summarizing what the authors did. So we will try to summarize what the authors did in terms of the method and also in terms of the results. And we will start extracting information and thinking about the information we need to write up the method section after today's session. In particular, we will need information about the key attributes of an economic evaluation, which is covered by today's session, the cost data, which is covered by the next session, and the outcome data, which is covered by session 4. Same thing for the results. So we will need to extract some information from the papers, and particularly related to the main analysis and any sensitivity analysis. And that will be done after session 5. And then at the workshop, which will be around early mid-March, we will do the commentary section, which I think is the most important bit of our manuscript. It's the most original in a way, because we will have to think about critically appraising the economic evaluation, thinking about implication for policy and practice, and also thinking about recommendation for future research. So these are our sections, and after each session, we will work towards trying to extract some information related to the method or to the results and so on. So what we're going to cover today, the aim is to understand and describe the key attributes of an economic evaluation. We will talk about the interventions being compared, including the population and the location or the setting. And then we will talk a bit more about the analytical approach, in particular the types of economic evaluation, sample size, perspective, time horizon, and then Luís will talk more in detail about the modeling techniques. So for some of you, all this information might be kind of familiar. I expect people know what the sample size is or the population. And of course, when we come to maybe the time horizon, the perspective, the modeling techniques, these are elements which are they tend to be associated with economic evaluation much more than other study designs. So these are quite peculiar to economic evaluation. So we will try to describe them in more detail. Any questions, please feel free to interrupt me or to write in the chat or to raise your hand. That's all fine. Okay, the intervention being compared. You will remember we had, I think, a slide in the session number 1 where I was trying to depict what an economic evaluation looks like. And any economic evaluation will always compare 2 or more interventions. Typically, you'll have a new intervention, which could be a new drug, new therapy, type of surgery, and that will be compared against the usual care. But there might be more than 2 interventions being compared, like 3 or 4, even more than 2 interventions that are going to be compared in an economic evaluation. Now, when you will have a look at your paper after today's session, we will ask you, as part of your homework, to extract some information regarding the interventions, the population, the sample size, etc., etc. And I'm trying to give you now some information about how to locate all these different elements within your paper. So the key information about the intervention, which we will need to include in our methods of our commentary, are the population, so the characteristics of the people or the patients targeted by intervention, for example, stroke patients or patients with advanced Parkinson's disease and so on. Type of intervention, which could be pharmacological or psychological or other forms of intervention, how they work, so any information about, for example, the type of administration, the frequency, the dosage. If it's a therapy, we talk about the number of and type of session, who delivers that particular therapy, who receives that particular therapy, and so on. If it's a diagnostic tool, we can try to extract information about the characteristics of the scans and the test and so on. And then we can also locate information about the particular location where the interventions took place, countries, regions, or cities, or even the type of care settings like primary care, secondary care, or other types of settings. This is an example of how to extract the characteristics of the interventions from a paper. So in terms of the population, so the target population, that should be clearly outlined within the aim of the study. So you might have a paragraph right at the end of the introduction describing the aim of the study, and in that paragraph you will also see some indication of the target population. The type of intervention and how they work, that's typically in the method. So if you open your paper, go to the method, and you will find maybe a subsection called intervention, maybe not, but you will find some information about the interventions and how they work. Similar for the location and the setting, could be described within the aim, but typically you will find that in the method section of the economic evaluation. And this is an example from an article from an economic evaluation which was on advanced Parkinson's disease, and we did a RaCEE around this economic evaluation a couple of years ago, and this is how we located this information about the intervention. So highlighted in green, you got information about the population, so patient with advanced Parkinson's disease. In yellow, you got information about the type of interventions and how they work. And you can see we found this information at the bottom of the introduction, but also as part of the methodological section, let's say. And also the location, which is highlighted here in pink. Now, I've just talked about this example. This is a RaCEE we published last year, and you can find this RaCEE in your team space. So if you click on the folder example previous RaCEE, you will be able to find the PDF there. And you will also be able to see how we summarize all this information from the original economic evaluation in our manuscript. So we try to be very concise and to describe the population, the type of interventions. For example, that economic evaluation was assessing the cost effectiveness of levodopa, carbidopa intestinal gel in comparison with standard of care. So we got some information about the interventions being compared here. towards the bottom of this paragraph, we also got some information about the type of intervention, how they work, and we try to summarize that, and also the location. So you can have a look at the PDF is there, and you can have a look how we try to write up the information, but that's not something you will have to do as part of your homework. Your homework will be more about extracting the information from the paper, so don't worry too much about the writing up bit. This is just to show you how we summarize things. Any questions so far? Just checking the chat as well. Okay, that's fine. Analytical approach. So I'm going to talk about the types of economic evaluation which could be used in a study, and then I will talk quite quickly about the sample, the perspective, and the time horizon, and then I will leave the second part of this today's session to Luís for the modeling techniques. So types of economic evaluation. This is a very big table where I'm going to try to describe different types of economic evaluation out there, and just so you can familiarize with the terms and with the different concepts. So let's start from the really the basic economic evaluation, which is the cost minimization analysis. You will see that for each type of economic evaluation, you will have some indication about how costs are measured and valued, how that particular type of economic evaluation identify the consequences or the outcomes, how it measure or value the consequences or the outcomes, and also in the last column there is an example of what that that particular economic evaluation looks like. So in terms of cost minimization analysis, there's no consideration about the outcomes because there is an assumption that the outcomes are equally effective. So let's have a look at the example in the last column. In this particular example, we are comparing the cost of administering a therapy to treat hypertension using two alternative modes of delivery. They are considered equally effective. One is in the hospital outpatient setting, and the second one is in private homes by involving community health staff. Now, this assumption that the two interventions are equally effective could be quite strong. It could be not really realistic in many cases. So that's the reason why cost minimization analysis are not really that common. They could be used in certain circumstances, but they're not really that common because of this strong assumption about the equal effectiveness of the interventions. Cost consequence analysis. Here we are really starting to consider the consequences, the outcomes a bit more. In particular, we are considering the outcomes in a disaggregated format. And let's have a look at the example and let's understand what we mean with the disaggregated format. So given that the assumption of equal effectiveness might not hold, we compare alternatives A and B in terms of cost, but also consequences. So things like acceptability, willingness to use, resource use, health outcomes. So all these outcomes are listed separately and we consider them separately. And then it's up to the decision maker to understand the relative importance of these outcomes. So they might think that willingness to use is more important than resource use. Okay, health outcomes are more important than willingness to use, and so on. So we just list all the outcomes separately. Cost effectiveness analysis, again, consideration of both costs and outcomes. But in this case, we are considering outcomes as a single effect of interest measured in natural units. So let's have a look at the example again in the last column. So we are comparing alternatives A and B in terms of cost and a single effect of interest, which is typically our primary outcome, measured by a reduction in blood pressure. So remember, the examples is really about hypertension. So the primary outcome will be something which is hypertension related, like, for example, reduction in blood pressure. And that is measured in natural units. With a cost utility analysis, which is a kind of a special case of a cost effectiveness analysis, we are still considering a single effect of interest, but is a kind of composite outcome. So cost effectiveness analysis, you got something which is clinical, could be reduction in blood pressure, or for example, cases of specific disease avoided and so on, avoided hospitalization as well. there's something clinical which could be related to the specific health or disease area. With cost-utility analysis instead, we are trying to measure healthy years, which is a composite outcome which takes into consideration not only the quality of life, but also the quantity of life in a way. So not only how well we live, but also how long we live as a result of receiving a particular intervention. So let's have a look at the last column. Again, we got this comparison between alternatives A and B in terms of costs and a single composite outcome measured by healthy years, which means estimating the quality of life changes and life expectancy of hypertensive patients being treated. The difference between the cost effectiveness analysis and cost utility analysis usually lies in the way we measure the outcomes. And with cost utility analysis, we got this concept of healthy years, which really could be applied to a lot in different health or disease areas. While with cost effectiveness analysis, we focus on clinical outcomes which tend to be specific to that specific health area, like for example, hypertension. So they couldn't really be applied to other health areas with the same degree of relevance, let's say. On the contrary, healthy years can be applied to different health or disease areas. And that's why cost utility analysis is, for example, the method recommended by NICE, the National Institute for Healthcare Excellence. And is the gold standard, let's say, type of economic evaluation which health economists use in the UK. That doesn't mean it doesn't have any limitation, and we will explore this limitation in session 4. The last type of economic evaluation is cost-benefit analysis, where not only we are trying to monetize cost, which is what we would expect to do, but also we're trying to monetize outcomes. For example, we can see that in the last column, we're trying to measure cost consequences in monetary terms by estimating, for example, how much the treated patients will be willing to pay for the therapy. So whether they assign a specific monetary value to therapy 1 or to therapy B and so on. Now, trying to monetize outcomes is not always feasible, especially when you try to monetize something which is intangible, which doesn't have, for example, market value, okay? So cost-benefit analysis are used, but they are not as common as cost-effectiveness and cost-utility analysis. Any questions?
Hi, Valerio, can I ask you a question?
Yeah.
Sorry, this is Money.
Yeah.
I just want to know the clear difference between cost-effective analysis and cost-benefit analysis. It sounds similar to me, slightly difficult to differentiate clearly from my aspect. It's the first time I'm hearing about these things. Sorry to ask a very silly question if you think that is... Yeah.
No, it's all right, don't worry. So cost effectiveness analysis, the outcomes are measured in natural units. Like we got some example here in the penultimate column. So life years gained, disability days saved, points of blood pressure reduction. So everything that is measured in natural units. Cost benefit analysis, instead, things are measured in monetary units. In a way, it's like you're trying to monetize the points of blood pressure reduction. So rather than expressing that in natural unit, you try to express that in pounds, right? So there is an added complexity to that. Of course, when you measure, for example, disability days saved or life years gained, you measure that and that's it. You got a number. When you try to monetize that, you need to ask people how much value they put on the different outcomes. So there is an added layer of complexity there. Is that clear?
Yeah, that's fine. That's better, actually. Yeah, thanks.
Okay.
Valerio, let me just say one thing because it works for me. I see cost effectiveness as an umbrella term. So it's basically everything is within cost effectiveness. So you have cost utility, you use the qualities as outcome. You have cost benefit, you use monetary terms. If it is something else, you just call it cost effectiveness. So that's it. It's cost effectiveness. You have those two very specific. If it is something else, you just call it cost effectiveness.
Like by exclusion, yeah.
Thanks, Luis. Yeah, that's useful. Yeah.
Okay. I'll carry on. Like, okay, this is another example on how to extract the analytical approach info from a paper, in particular related to types of economic evaluation. And it's the first thing I'm going to say now is kind of linked to what Luis was saying a second ago. First of all, do not jump to conclusions. The term cost effectiveness is mentioned a lot. And just because you see that a lot in an article, it does not necessarily mean that the authors conducted a cost effectiveness analysis. If you remember the titles of our papers before, all of them mention cost effectiveness, probably, if I remember well. That doesn't mean they conducted a cost effectiveness analysis. There are two different things. Cost effectiveness is an umbrella term and is often abused as an umbrella term. So the way we go and determine the types of economic evaluation used by the authors is by carefully checking the outcome measure used by the authors in the method. And like Luis was saying before, have a look what outcomes they used. If it's like QUALIS, it's a cost utility analysis. If it's something monetary, it's a cost benefit analysis. But if it's something else, maybe it's a cost effectiveness analysis. Here you got a few examples. So cost per 1 point reduction in blood pressure, which is or another specific clinical outcome. Then you got a cost effectiveness analysis. If you got a cost per additional health year, which is typically measured by quality adjusted life years, so QUALIS, we will cover QUALIS in session 4, so don't worry about them for now. You got a cost utility analysis. In the article on advanced Parkinson's disease, which I mentioned before, the authors conducted a cost effectiveness analysis and a cost utility analysis. So you also need to remember the types of economic evaluation, they're not mutually exclusive. Authors can do a cost effectiveness analysis, cost consequences analysis, cost utility analysis. Okay, so they can do the number of economic evaluation they want to do. To be honest, there's no limit to that. And you got the information about the types of economic evaluation here highlighted in green. So they use QUALIS, so we got a cost utility analysis, but they also use life years, which is something measured in natural units. It's not really composite, so it's a cost effectiveness analysis. Any questions? Okay. I'm going to cover these elements a bit quickly now. I think we are all aware about what the sample is. So you will find information about the sample, the type of participants in the paper, and that it's just related to the size of the sample used for the analysis. That's different from the population. So the sample will have some specific characteristics like inclusion and exclusion criteria, which makes the sample a kind of a subset of the target population indicated by the authors in the aim, for example. The perspective, this is very related to an economic evaluation, and it covers the range of costs and outcomes considered. So it could be that the authors consider the costs and outcomes impacting on the health and social care system only, or on the society more widely. So if you think about intervention, for example, for the health of children, right, you could be having effects which are impacting on the education system. You could have an intervention which impacts on the parents, so whether they need to take days off work in order to assist their children. So you will have some externalities, we call them like that in economics, some external effects which might impact on other elements of the economy. If you choose to focus on the health and social care system only, then you won't consider any societal impact from the intervention. Now, this choice is driven in the UK, at least, by, again, NICE, which recommends to use the perspective of the health and social care system as a minimum. So you can add other things, but of course, when you add other elements from other societal impacts, it will become increasingly difficult to capture and to measure these elements. Time horizon, it reflects the time scale of the analysis, which could be short-term. So if an economic evaluation is run alongside a randomized control trial, you will have probably a short-term analysis of, I don't know, 6 months, 1 year. So that's just the time period of a trial. Or it could be longer term. So there are methods, and Luis will discuss them later on, which allow to extend the analysis to, for example, the lifetime of the individuals. here is some indication where you can find information about the sample, the perspective, and the time horizon in the papers. Usually, these things tend to be in the method or in the results. So for the sample, you will find some indication on the sample side in the results, possibly just right at the beginning. For the perspective, you will find information about that in the method, and the same for the time horizon. If you struggle, just do a quick search for example, perspective or horizon, and any good economic evaluation will include the term perspective within it. So I know it sounds a bit very basic as a method, but if you struggle to find information, just do a Control F, a quick search, and you will find the term perspective somewhere in the method, or the term time horizon somewhere in the method. And here you got the example again using the article on the advanced Parkinson disease interventions. You got information about the perspective, which was at the bottom of the introduction. And then in the method section, information about the sample highlighted in pink, and the time horizon again within the method section. We had a time horizon of 20 years. And this is just to show how we wrote up the analytical approach info in terms of a type of economic evaluation, the sample size, and the time horizon. So you got this slide as a reference. You can have a look later on about, how we summarize all this info. Now, before I move to Luís' section, do you have any questions so far? I'll stop sharing then. Luís.
Luís, you are muted if you are talking. Sorry.
True. Thank you so much. Okay, so can you see it?
Yeah, we can see it. It's fine.
Okay, let me. Valerio already gave you a lot of information. I'm going to give you a lot more information. So if you are feeling a little bit overwhelmed, it's normal. We are condensing a lot of material in these sessions, but the objective of this course, it's not that you are going to leave this course knowing how to do an economic evaluation or fully understanding an economic evaluation. Is to make you slightly more comfortable, or slightly less uncomfortable around these terms. It's that you can look at the paper and understand what is being done and interpret what is being done. That's the idea. So that said, I'm going to explain how to model in economic evaluation. So if you have any question, please feel free to just unmute yourself and ask. And again, if by the end of it you still don't understand everything completely, don't worry, it's normal, because this is going to be fast. So, okay, there are possible models to do an economic evaluation, and the ones that you are going to find are going to be these three, which are the decision trees, the Markov models, and discrete event simulations. So they are basically going to depend on your needs. They are going to depend on the type of intervention, treatment, the type of health condition, the time horizon that you believe is suitable to be modeled, and that's basically it. So decision trees, I'm going to show you just in the next slide. They are basically used when benefits and costs depend on states. So basically they are always used. It's just that you are going to see some economic evaluations where they don't explicitly show decision trees, but it's just because they are already doing it in terms of variations against the standard of care. But yeah, basically you need to start modeling with the decision tree. What are the possibilities? What are the treatments for each treatment? What are the different outcomes that I may get? And for each type of different outcomes, what are the costs as well? So we are just going to see it. Then the Markov models is when you care about time. You believe that things may change across time, and you want to model that evolution of the disease, of the condition through time more effectively. They are literally an extension of decision trees. It's just that doing decision trees several times across time, it would be very complex. So people turn to these Markov models, which allow to extend the decision trees through time. And then discrete event simulations, let's say it's an upgrade in some sense to the Markov models. They are just some simulations that you, instead of doing as a cohort, which you are going to see, you do it individually. It just gives people more flexibility to model more complex and hopefully more realistic models. But that's it. So let's see them, because right now they are just names. Let's try to have a visualization of what they are. So a decision tree is this. So it's pretty, I think it's pretty simple. So far, don't look too much at the letters and so on. Let's just follow the decision tree. So we have potential treatments that we want to choose. So in this case, treatment X and treatment Y. So first thing is that we have these two options. So those are the first nodes. So treatment X or treatment Y, the first choices. And then in this very simple example, within treatment X, as you can see, you have the possibility of the person being cured or the person being not cured. Okay. So one thing, you are going to see that below cure, you can see some px. This is the probability of being cured through treatment X. Okay, so with some probability, with this treatment, you get cured, and then you will see that below no cure, there's a 1 minus px. So it's basically the inverse probability. So if you get a probability of cure of 20%, it means that the probability of no cure would be 80%, for example. Okay, so that's just it. It's not very complex, but feel free to unmute yourself and ask me questions anytime. Now, if you get cured, you will have a certain health outcome. In this case, this is life years or life expectancy. And you live a certain amount of time. If you don't get cured, you have another life expectancy. In this case, it should be lower. That's it about the outcomes. Now, there should be also costs. And in this case, here they are modeling it as you pay the treatment costs, which is the first term, and then you pay just for staying alive, for living. So it's a treatment cost, and then there's an yearly cost times the life expectancy. So the same for no cure, you have the treatment cost, which should be the same as the cure one, and then the yearly cost, which again should be the same, but multiplying by a lower life expectancy. And then treatment Y is exactly the same. It's just that the parameters are going to change. So the probability of cure is going to be Py, so it can be bigger or smaller than Px, so it's another probability. And of course, the probability of not being cured is the difference is 100% minus that probability. So again, let's say this in this case is 30%. It means that no cure would be 100% minus 30%, which would be 70%. And again, the same stuff, some life years if cured, they should be the same. If the cure is effective, is equally effective on both treatments, should be the same. And then you have the treatment cost, which should be different. And then again, the yearly cost times the life expectancy. And the same in the other node of no cure. It's just kind of a replication. So let's put some numbers into it and let's look at it. So let's assume that treatment X has a 75% probability of cure and a 25% probability of no cure, while treatment Y in this case is more effective. So it has a 90% probability of cure and only a 10% probability of no cure. So, of course, in case of cure with treatment X or treatment Y, the person lives 30 years. And in case of no cure, both with treatment X and with treatment Y, the person lives 20 years. Now, treatment X, you will see that costs $10,000. So this is in dollars, so $10,000, while treatment Y costs $100,000. So let's continue here in the first node in the cure. Then you have, of course, the cost of living, which in this case they compute as $1,000 per year, and they multiply it by the amount of years lived, so by 30. And if you do this computation, for instance, in this case, in the treatment X for cure, you get $40,000. Okay, so if you go to, for instance, treatment Y cure, it's the same, but here you have a bigger cost. So you have these $100,000, and then you sum the 30 years living times these costly this cost of being alive for 30 years, which is 1,000, and you get this 130,000 pounds, no, dollars, sorry. So, okay, so the idea in general is very simple, is this, is for each node, what you want to do for each node is to then get the outcome, so the life expectancy, and get the costs. Once you do this for each node, you are then able to compute the cost effectiveness. So in this case, the cost effectiveness is going to be in terms of life years per cost. So let's compute it. It should not be too complicated. So we can first start with computing the expected costs for treatment X. We already have that the expected cost is for the expected costs for the treatment X. So we have that if the person is cured, we already have the cost computed, is going to be this 40,000 pounds. If the person is not cured, is going to be this 30,000 pounds. Now, the only thing is that there is a probability of being cured and the probability of not being cured. So we just have to multiply the probability of being cured times the cost. So 75% times 40,000 pounds plus not being cured is 25% times 30,000 pounds. And you get this 37,500 pounds. Now, you can do the same for treatment Y. You have that the cost of being cured is 130,000 pounds. And then the not being cured is 120,000 pounds. So you can again multiply it by the probabilities, 90% times the cost of being cured plus 10% times the cost of not being cured, and you get these 129,000 pounds. So sorry, dollars. I'm going to pounds, but it's dollars. It doesn't matter anyway. So then you have the expected benefits. You can also compute it for treatment X and for treatment Y. You have, again, with 75%, the person is cured in treatment X, so it's 30 years, plus 25% times 20 years, and you get this 27.5 years. That is the expected life expectancy under treatment X. Then the expected life expectancy under treatment Y is going to be 90% times 30 years plus 10% times 20 years, which is 29 years. Now, I know this is going to be later taught in a sense, but then you are able to compute the ICER, which is the incremental cost effectiveness ratio. And there will be a class for this. I'm just jumping ahead, and you can compute it. So you can literally see how much is the extra cost of this treatment Y compared to treatment X. So you can do this $129,000 minus the $37,500 and this is the extra cost. And then you can divide it by the extra efficiency. So you live more under treatment Y, so 29 years. So you can do 29 minus 27.5. And you get the difference. You divide the difference of the costs by the difference in the effectiveness, and you get your cost per effectiveness. So in this case, each life year gain is going to cost $61,000. And that's how an economic evaluation would be done under a decision tree. So any question? It was a little bit fast, but do you have any question? So, okay, I'm going to move to the Markov models. Again, this is just for you to have an idea. We don't expect you to be able to use these tools. It's just for you to look at them and recognize them and understand more or less how they are working. Now, the Markov model is slightly trickier. The idea of the Markov model is that these nodes would be extended. So imagine that in this case, it's not the best example because it's cure or no cure. But sometimes it's just some states that can lead to others. So imagine that now within the no cure, you could continue your decision tree for another year, and you could give another treatment, and then it would be again cure or no cure. And then within the no cures, you could continue on giving more treatments to try to get the person treated, and this would continue across years. So this is the idea of the Markov model, is to continue the decision tree for many, many years. So I'm going to give you this very simple case where people can have 3 states, basically. They can be asymptomatic, and they can stay there, or they can go to progressive, or they can die. So you will see that there's some errors here. So if you start as asymptomatic, you have the possibility of staying asymptomatic. Then you have the possibility of going to progressive, or you have the possibility of dying automatically, either because of natural causes or because of disease causes. Now, within progressive, again, you have the possibility of staying progressive, or you have the possibility of dying. Okay. So these are your states, and this is how you can move within your states. Now, for each of these movements, there are ways through randomized control trials and so on that you can compute the probabilities of moving between states. So in the table below, what you are going to be are these probabilities. So if you are asymptomatic, you have a probability of 66.67% of staying asymptomatic. And you have a probability of 16.67% of going to progressive. And you have a possibility again of 16.67% of dying. Okay. Now, if you are progressive, you have a probability of 66.67% of staying progressive. You cannot go back to asymptomatic. It's done. And you have a probability of 33.33% of dying. If you are dead, of course, you cannot leave it. So it's 100% probability of staying dead. Now, the idea is to do the following. You start a cycle, and in the first period, everyone is asymptomatic. Okay. And then because you have these probabilities that you know, that you acquired from doing analysis, from doing randomized control trials, you can know in 1 year how many people here should go to asymptomatic, how many people should go to progressive, and how many people should go to dead. Now, you do it 1 year, and you get all the person moving, then you do it another year, and another year, and another year. So what you are going to see in here is that you start at cycle 0 with everyone asymptomatic, and then by cycle 8, just some of them stayed asymptomatic, and most of them already went to progressive, and some of them are already dead. Then in this cycle N, which can be, let's say 20, only 1 person is asymptomatic, 2 persons are progressive, and most people are already dead. And you continue these cycles on what you believe to be, for instance, let's say the expected life of those patients, or until everyone is dead. Now, I'm going to show you an example. So this is slightly more complex than this one. It's just another state. So the first that we saw had asymptomatic, progressive, and dead. So this one, just assume that you have something else. So you have asymptomatic, then in progressive, you have a not so bad state and a worst state, and then dead. But it's exactly the same. You start with everyone, let's say in asymptomatic. And then you can see in year 1, you basically have the probabilities of transition. So the probability of staying asymptomatic in 1 year is going to be this almost 70%. The probability of going to the not so bad state is going to be almost 20%. the probability of going to the very bad state is almost going to be this 6-7%, and the probability of dying is going to be this 1%. Okay, so you do that for 1 year, and you can compute the life expectancy. For example, in this case, only 1% die, so it means that 99% stay alive. So the life expectancy is 99%. Now you can do it for a second year. So you basically are just going to apply these probabilities here, and just use them to find how many people should be in each state in the second year. And you'll see that in the second year, for example, you have 52% in asymptomatic, so 26% in the not so bad state, 18% in the bad state, and 3.6% already dead. And again, you can compute the life years, and you get that 96.4% are alive at the time. Now, each state should be associated with some type of cost. So, of course, asymptomatic, let's say, no cost. Then the not so bad state, a certain cost. And then the worst state, a worst cost. And then dead, no cost because the person dies. Now, you can kind of multiply these probabilities by the costs, and you can also compute the costs on another column. Now, you can do this for 20 years, as you can see. You can see that by the 20th year, only, well, less than 0.1% of the persons are symptomatic. Only 0.2% of the persons are in the not so bad state. So 2.8% of the people are in the bad state, and most of the people had died already, 96.8%. So you will see that the life expectancy for this year is very, very low. Now, if you sum all of these, you basically get all the life years that you have throughout the 20 years, and then you get all the costs for each year. So like we did with the decision tree, if you want, you then have for this treatment, you have the amount of life years gained, you have the amount of the costs. Now, if you repeated the Markov model for another state, for another treatment, sorry, you could also compute an ICER where you have the life years for each of the treatments, you have the costs for each of the treatments, and then you can compute the ICER and have your outcome. So, any doubts so far? How am I in terms of time? Sorry, Ruben.
Yeah, a quick one. So Luis, thanks for the probability. Is it from like a life table, or how do we usually get the probability of
Yeah, the probabilities is the tricky bit. You need to get them from for instance, randomized control trials. So imagine that you do, I don't know, you are doing a randomized control trial for some treatment. For example, I can show you this one. This one is again from the paper that we are using, that we did our first RaCEEs on, and what they had was Parkinson's disease, and they had a new treatment that they wanted to check. And within Parkinson's disease, they had several states. So these HY, you can see them as the severity in some sense. So it could be from level 1 severity to level 5 severity. And they would also have off time, which is the time where people wouldn't be. I'm not an expert in Parkinson, but the idea is that they are off. They are not able to do the things they usually do. They are, the disease just doesn't allow them. And there's also depending on the amount of time that they stay off, there would also be 5 levels. Now, what they do is they use randomized controlled trials from other studies, where they basically see that, for example, for each state that they are, what is the probability that with that treatment they move to another treatment, to another severity level, for example. So yeah, you really need to do them from randomized controlled trials. Is just you apply the treatment, and you have several people on different severity levels, and then you just see you accompany those people for a certain amount of times. It can be 1 year, 2 years, 3 years. You accompany them, and you accompany them, and you see that, for example, for 1 year, how many people with this treatment that were in this state, how many people moved to another state, and you get the probability based on that. Okay, was that more or less clear? Ruben?
Hello.
Hello.
That's very helpful. Thank you.
Okay, so how much time do I have?
We got probably 1 minute, and then
1 minute. Okay. So that's not a lot. So I'm going to skip this one because I already talked about it. Let's just go to discrete event simulations. So discrete event simulations are just, let's say, more complex form of a Markov model. The idea is still the same. The idea is still that you have several states and you want to see how people move between states across time. It's just that it gives you a little bit more flexibility. So I'm just going to show you this example. This is from, there's a student of mine that is working on this, and she may or may not use something like this. This is an example for angioplasty for intrauterine arterial disease with use of percutaneous transluminal angioplasty. And you will see that while you probably can do it with a Markov model, this is a little bit more complex. So you enter a model, and in the model, you receive this PTA, so this percutaneous transluminal angioplasty intervention. And then once you receive the intervention, there's a 30 days outcome where you can die from general mortality, or you can die because of the procedure. And then if you don't die, you can stay alive and patent. So this is the good outcome, or you can have an acute failure. In case you have an acute failure, you can you will be in this state of on loss of patency, where you can develop contralateral symptoms, or you can have disease progression. And in this case, you are going to need a reintervention. Of course, you can also go to general mortality. But if you receive the intervention, you see that you fall here within the reintervention, where you can receive PTA or bypass surgery, or you can go to the amputation. And again, you can go to general mortality, procedure-related mortality, the same if you receive PTA or bypass intervention, general mortality or procedure-related mortality. And you continue. So if you stay alive and patient, you will see that you can have late failure, and then you go here again to on the loss of patency. But if you or you can just stay there. If you develop contralateral symptoms, again, you go to a reintervention, which may be an amputation, or it may be a PTA or bypass surgery. And that's it. And you continue on this loop. So it's very similar to the Markov model. The idea is more or less the same. It's just that computationally, it's a little bit harder. You do these simulations where you will need a lot more parameters because you have a more flexible design. But the idea is more or less the same. So these are basically the three things that you are going to find in your economic evaluations: decision trees, Markov models, or discrete event simulations. So yes, just one left. So how to write a methodology. So you can see that in the original one, in this section of model structure, we could find. So a Markov model was developing using the NHS and personal and social sciences perspective. So you have the information in here. Now, what you can see on the left, what we did. So the authors used the Markov model to estimate incremental cost effectiveness ratio. You can see how we did it. So we have the type of economic evaluation. You can see here that we are referring to the states, the amount of off-state that they spend, and the severity, which is this O and NDR, the HY that we were seeing. Again, here you can see the type of economic evaluation in the first part, and again, the L states, the part talking about this HY scale, and the part talking about the off time of the patients. So, okay, now back to Valerio.
Thank you, Luis. Just to cover the homework very quickly. Luis, are you happy for you to move the slides? Yeah. So all we talk about today, modeling techniques especially, it's just to give you some reference about, if you see decision tree, Markov modeling in your paper, you can have a look at the slides, and so you're familiar a bit more with these terms. We're going to ask you now, following this session, to fill in a table with info on the key attributes of the economic variation, and we're going to ask you to complete this task by Monday, the 2nd of December. Next slide, please. So you can find the table under session 2 on your TeamSpace. You open the folder for session 2, and then you will see a document with your name. You can open that document, and then next slide, please. You will see the table there. So this is the table we are going to ask you to fill in. You got some information in the first 3 columns. For example, for population, you got definition of population, where you can find that info within the paper. And then what we're going to ask you to do is extract that info from the paper and copy and paste it if you want, to summarize it if you want, whatever you want to do. And the same for all the other attributes, so type of intervention, location, setting, and so on. So for each of them, you got a definition, where you can find it, and then you will need to extract that information. If you struggle, we are there. So the team leads will be there to help you, okay? Next slide, please. So this is all from today, and sorry we we overrun a bit. The next session will be on 2nd of December, same time, same place. We will cover costs, and if you got any questions about today's session, we're happy to stay for another 5 minutes or so. But otherwise, I just wanted to thank you for joining the session today. And if you got any question about the homework, please let us know. We are there to help you. Thank you very much, everyone.
Thank you.
Thank you.